Hello, my name is Darnina Greenhow, and I will be presenting a case study of a patient in the acute care setting. Miss X is a 68-year-old Caucasian female who presented to the emergency room with complaints of left knee pain. Miss X resides in a local nursing home and is bedbound. She reports her left knee started hurting after she bumped it while being transferred via mechanical lift from her bed to her wheelchair. Miss X has an extensive past medical history to include anemia, cerebral palsy, atrial fibrillation, diabetes mellitus, diabetic neuropathy, deep vein thrombosis, epilepsy, gastroesophageal reflux disease, glaucoma, hyperlipidemia, hypertension, peripheral vascular disease, and osteoporosis. Miss X was subsequently admitted to the hospital with a diagnosis of having a closed, non-displaced fracture of the lower epiphysis of her left femur. Pathophysiology. A bone fracture can be simply defined as a break in the bone and is usually the result of some type of forceful trauma. Miss X suffered a closed, non-displaced fracture. Dr. Kakar, an orthopedic specialist, explains in his online article that a fracture is considered closed because the broken bone did not break through the skin and is non-displaced because although there is a break in the bone is still in a proper alignment. The most common signs and symptoms of a fracture include pain, swelling, bruising, and tenderness at the site. Miss X expressed pain of 10 of 10 and had noticed swelling and tenderness to her left knee. Her history of osteoporosis puts her at greater risk for sustaining a fracture because her bones are fragile and weak. Zellman et al., authors of the textbook Human Disease, A Systemic Approach, describes osteoporosis as a spongy bone that is unusually brittle and vulnerable to fractures. It affects mostly Caucasian women over the age of 50 who are postmenopausal, have had a hysterectomy, have low bone mass density, have a diet that lacks calcium and vitamin D, and who live a sedentary lifestyle. The fracture Miss X sustained was located at the lower epiphysis of her femur, which is indicative of trauma occurring from the knee bump. Unfortunately, because she has osteoporosis causing her bones to be weak, extreme force isn't necessary for a fracture to occur. Laboratory tests. Laboratory tests are not necessary to diagnose a fracture. However, Ms. X must be hemodynamically stable prior to any possible surgical interventions. A complete blood count was obtained, revealing Ms. X was acutely anemic. Her hemoglobin was at a 6.1 grams per deciliter, and her hematocrit was at an 18%. According to the National Heart, Lung, and Blood Institute, anemia occurs when red blood cells lack adequate oxygen because the iron-containing protein hemoglobin that aids in red blood cells transporting oxygen throughout the body is low. Based on the Cleveland Clinic, the normal range for hemoglobin for a female is 12.0 to 16.0 grams per deciliter, and the normal range for hematocrit for a female is 36 to 48%. Hematocrit is a measurement of the number of red blood cells in the body. Miss X received 1 unit of packed red blood cells in an effort to stabilize her hemoglobin level. Radiological test. Initially, Miss X had an x-ray of her left knee while she was in the emergency room that revealed the femur fracture. After being admitted to the hospital, a CT scan was ordered. The CT scan showed that there was a spiral fracture involving the distal diaphysis and metaphysis of her left femur. It also shows significant osteopenia, which is consistent with her osteoporosis. Editor Rachna of biodifferences.com explains an X-ray and a CT scan both take internal images, but an X-ray produces a two-dimensional image, whereas a CT scan produces a three-dimensional image and is capable of detecting injuries and damages to muscles, organs, and soft tissues. Current evidence-based practice. Orthopedic specialists at the University of Lynchburg did a study reviewing the treatment of distal femur fractures and concluded that open reduction internal fixation, also known as ORF, and intramedullary nailing are the traditional treatments of distal femur fractures, but per current evidence-based treatment, performing a distal femoral replacement or arthroplasty proves to be more beneficial to the patient. This procedure increases weight-bearing capabilities, increases mobility, lessens the need of a brace, and allows patients with osteoporosis the ability to function optimally. Ms. X underwent the intramedullary nailing of her distal left femur. Expected treatment outcomes and general prognosis. Experts at Johns Hopkins expect a recovery period of 4 to 6 months, with majority of patients recovering without complications, such as a fat embolism, infection, or blood clots. Patients are prescribed pain medications and an anticoagulant medication to reduce the risk of developing a blood clot. They suggest a person healing from a femur fracture with repair participate in a physical therapy regimen to regain strength and mobility of the affected limb. Prognosis of patient versus general prognosis. Considering Mrs. X's medical history and immobility, her recovery time will extend beyond the general expected recovery time of 4 to 6 months. Her ability to participate effectively with physical therapy is limited due to her cerebral palsy and her being immobile. She is also at greater risk for developing a blood clot as she has a history of a deep vein thrombosis, atrial fibrillation, and immobility. Nursing care for the patient. Directly after surgery, it is imperative that nursing applies sequential compression devices, also known as SCDs, to Mrs. X's bilateral lower extremities. Evidence-based practice has proven this to be successful in decreasing a post-operative patient from developing blood clots. Ms. X will be returning to the nursing home where she is already an established resident. Nursing will need to focus on pain management, monitoring vital signs, encouraging mobility within her limits, and monitoring of her incision site for signs of infection such as redness, swelling, or excessive or purulent drainage. Appropriate family patient education. The patient and her family should be involved in the recovery process. They should know it is important to keep the area clean and dry and to report any redness, increased drainage, or if the incision appears to be opening up. Pain medication can be used as prescribed to manage pain. The use of a leg brace, also known as an immobilizer, may be used to aid in healing and to ensure proper alignment. Medical professionals at Mount Sinai suggest keeping the area around the patient free of clutter with personal belongings within reach. And if at any time the patient feels short of breath, has a temperature of 101 degrees Fahrenheit or greater, experiences a nosebleed, blood in the urine or stool, or pain or swelling in the calf of the affected leg, then their primary care physician or orthopedic specialist should be notified immediately. Summary. Ms. X suffered an unfortunate injury to her left femur. She has a long road to recovery as she has several factors such as her diabetes and sedentary lifestyle that will impede the recommended healing time. She is at greater risk of re-injury or sustaining another fracture due to her osteoporosis and decreased immobility. She will need constant monitoring of her anemia, risk of DVT, continued physical therapy, pain management, and support from family and nursing staff. This concludes my presentation on a case study of a patient in the acute care setting. Thank you.